Hello, and welcome to the Medicine Matters Diabetes podcast. I'm Eleanor McDermott. The COVID-19 pandemic has created challenges for everyone, but particularly for people with long-term conditions such as diabetes. For this episode, health psychologist Michael Vallis, Associate Professor of Family Medicine at Dalhousie University in Halifax, Canada, discusses the psychosocial impact of the pandemic on people with diabetes and how healthcare professionals can identify and support those who are struggling. Can you outline what psychosocial impact the pandemic is having on people with diabetes, both in a general sense and specific to having a chronic condition?
So the pandemic is actually posing a big challenge for its citizens in general, but maybe even more specifically for individuals living with diabetes. I think it's important for us to recognize that the pandemic has really affected pretty much all of our aspects of functioning. And as a result, I think we need to be open to asking ourselves, what effect is it having on us? And how do we seek adequate support for managing the stresses associated with the pandemic, and also the potential that the pandemic has had to influence our self-management? And so if individuals living with diabetes are not taking as good care of themselves in some ways, how do we support that? So it's, I think, been an opportunity to revisit the importance of psychosocial issues on diabetes management.
Can you outline in a bit more detail what this impact is?
So the pandemic has provided a game-changing shift in the context. So human behavior is really oriented towards routines and patterns. There's more attention to issues than we have resources to focus on. So, how do we manage all of the sort of balls that we have to juggle in a day? And what tends to happen is that we put things into automatic processing. So this is really very important. And so one of the ways to understand what COVID and the pandemic has done is pretty much changed everybody's routine. So all of a sudden, there's a tremendous impact. And so you can't just go on as if things were normal. And so this has been a bit of a shift, especially since what happens is that increase in stress that's associated with just the change is also associated with increased in potential for problematic reactions. So one way to understand this is really just a general perspective would be, what am I feeling and why? So this is a very broad perspective on how emotions work. And it's actually quite straightforward. If you have the perception of threat, so you find yourself in a situation where you're feeling threatened by something, then that's going to naturally produce the feeling of anxiety. If you're in a situation where you perceive a loss, you will naturally feel sad. If you're in a situation where you perceive injustice, unfairness, you will feel anger. So all of a sudden, we could ask the question, does the pandemic provide you with any threat? Does it produce any loss? And is there any sense of injustice? And if we look at what's happening in the world, we see a lot of anxiety for people who are feeling really the threat, the what ifs. If you have diabetes, well, that puts you potentially at greater risk. So there's a threat for everyone living with diabetes. Many of us have had routines and strategies that we're unable to participate in because of the pandemic and associated behavior changes. So we've experienced losses. And then there are a number of people we see in the news quite commonly who are kind of fed up and tired of being told what to do, tired of the sort of restrictions placed on them, and they perceive these as unjust, and they are reacting with anger. So this is an important observation because the pandemic has really changed our lives in a way where anxiety and sadness and anger or irritability all become normal experiences. And then we might well anticipate. So for instance, individuals facing increased lockdown or restrictions because of changes in the sort of demographics, what is that doing? And you'll see people who go through those stages. So one of the important things from a psychosocial point of view is to understand what's normal and what's not. And we tend to have a strategy where we're sort of thinking, okay, if I'm feeling fine, then things are normal. And if I'm not feeling fine, then something must be wrong. And in a case like this, what's wrong hasn't got anything to do with us but the world. And so this is where there's a natural relationship between what am I feeling and why, and then what can I do about it? And this is actually really important for healthcare providers to recognize. So endocrinologists, diabetologists, nurse dietitians, all of these individuals who might say, my scope of practice is really the mechanics of diabetes management. Well, there's an opportunity for us recognizing that to be anxious during COVID is normal, to feel sad during COVID is normal, to perhaps be irritable or frustrated because of COVID is normal. This then puts the diabetes provider into that very familiar territory for us, which is we know that diabetes outcomes are based on the patient's self-management. So one of the things that I think COVID provides an opportunity for is helping the diabetes provider become a little bit more comfortable providing the adequate support for the individual living with diabetes, particularly since there may be threats and losses that would be associated with the disease that puts someone living with diabetes perhaps at a greater chance of experiencing some of this distress.
And what have we been finding has been happening specifically with people with diabetes? Have we got data? Do we know what the outcomes have been during the pandemic?
Those living with diabetes have been at risk really of avoiding care. And so we're starting to see some evidence that suggests things like diabetes ketoacidosis. So when your sugars get really, really high to the point where it becomes a medical emergency. Well, if people are not taking good care of themselves, this becomes a risk factor. And there's beginning to be a little bit of a signal about increased admissions for DKA. The type 1 diabetes diagnoses usually requires sort of emergency consult with physicians, and there's some indication that perhaps there's a delay in that as well. And then people avoiding care, avoiding their appointments out of the concerns that they have. So one of the things that's happened here that's very much specific to living with a chronic disease is to look at what we call health beliefs. This is a very important aspect of the psychological experience of diabetes. And a provider can understand this quite quickly by just thinking about two perceptions: perceived need and perceived concerns. So one could think about, let's say someone was having their medication regimen changed. So the doctor asks the patient to go on another medication, or let's say switch to insulin or an injectable. And we might ask the question, okay, in a situation like this, what's important about the patient's willingness to follow those recommendations? And this model becomes really useful because you could ask the patient, to what extent do you need this treatment to benefit your health? What's your self-perceived need? Second question, to what extent do you have concerns about this treatment? Self-perceived concerns. So needs and concerns, all of a sudden, just imagine you've got the following scenarios: an individual with high perceived need and low concerns. Now, this is an accepting person. This person is much likely to just follow the clinician's advice. What if you had an individual with high perceived need, but high perceived concerns as well? All of a sudden, we call this ambivalence. The person is kind of wants to go, but doesn't want to go. What if the perceived need was low and perceived concerns were low? We call this indifference. And then finally, if you had low perceived need, but high concerns, we call this skeptical. A lot of this quote unquote anti-vaxxers that we're seeing kind of come out of the woodwork now, they have high concerns, low perceived need. Now, the point of saying this around the health belief is that it's pretty easy to assess that. And you don't have to be a psychologist to assess that. anyone can ask the individual living with diabetes. My point here is that during the pandemic, perceived concerns have gone up. So this is another important aspect that we can help our patients, rather than becoming frustrated by these shifts in attitudes in which perhaps they're not accessing care. They're actually doing that based on their perceived increased concerns. And if we can address those concerns, I think we can actually help the patients to get back into the care plans that they have.
That's a straightforward way of identifying the people who may be struggling. When you've found them, how do you to support them? I mean, how do you support people in general, and how do you support people who have specific needs related to their diabetes?
One of the things that we've identified in the 8 months or so that we've been living with this pandemic is that it's had a pretty strong impact on individuals. Many of the surveys looking at the stress levels are showing that stress levels are really high. So this tells us that it might be important for us to promote stress management. There's a basic principle, which is the higher the level of stress, the lower the level of self-care. This is just very natural. Stress tends to overwhelm a person, makes it more difficult for them to engage in good self-care. And since diabetes rests on self-management, there's this very common relationship between stress and self-care. And so this tells us that we might want to look at how our patients are coping to support coping. And again, this is an important issue from a psychosocial point of view, because for some of our patients, they do require referral to mental health professionals to manage their stress, particularly if they have excessive unhealthy stress that really interferes with their functioning. But during COVID, what we're finding is just the stress signal increasing for everybody is actually making it challenging. And so this becomes an area where the diabetes provider can actually be helpful. When it comes to coping, there are really two styles of coping. Sometimes people, when they're in a stress situation, they turn the volume down. They sort of push the stress away so they can keep focused on action. By the way, most healthcare providers are like this. They are really good at action-focused coping. But action-focused copers sometimes don't spend enough time on their own emotional needs, and these people can be really vulnerable to substance abuse, to irritability, to outbursts. Then there are the people who are what we call sensitizers. They focus in on their emotions, and they really pay very close attention to their emotions. And the challenge in this current situation is perhaps that can get them to the point where their distress level gets really, really high. So what this provides to us as a health community is that if we encourage our patients to manage their stress, both the specific stress associated with their diabetes and the more general stress, this can be really helpful. We actually know a lot about stress management, and I can summarize that really quite quickly. First thing is, what are we actually looking for? And what we're looking for is a stress management activity that meets the following three criteria. We recommend it to our patient. When they hear it, they're interested in doing it. Step number one. Step number two, they try it and they like it. Step number three, they want to do it again. So the evidence on stress management tells us that there isn't one stress management strategy that fits everyone, but that stress management fits into a number of different categories, and it's a highly individual approach. And so that then provides us with the opportunity to recommend stress management. And there are 5 independent stress management strategies. And they're quite simple and quite straightforward. They begin with first what we call physical calming. So recommending to our patients that they find opportunities to have calm, peaceful, reflective moments in a day. This could be through meditation, relaxation, Tai Chi. It could be a relaxing activity like sitting by a fire or reading a book. It could be prayer, anything that allows the individual to sort of bring their level of stress down. We call that physical calming. Second, physical discharge, any form of burning off the stress, physical activity, dancing, running, jogging, anything that would give this person the sense that they burnt off that excess energy. Third, what we call social connection. And this we know is really important. Reaching out to others is a way of really managing stress. Fourth, emotional expression. And if you think about any form of art, it's very much around expressing emotions. And then finally, what we call sort of acceptance or mindfulness, the ability to just accept the moment for as it is without over-evaluating it. So in other words, there's 5 different strategies. We could provide a 2 or 3 minute education to our patient, recommend that they consider these activities, and then support them finding the ones that fit to themselves. And so the next time you're interacting with our patients, you might think about whether a few minutes of advice around this could actually be helpful. This then gets us into the diabetes specific aspects of the stress management. And I think the important thing to understand with that is the stress might well interrupt the patient's focus on self-care. And this is where the patient-provider relationship becomes so important, because the patient-provider relationship, where the patient feels that they've been understood by their provider, where they feel that they've had an opportunity to express their concerns. And once they've had that opportunity, then the clinician is then able to support and encourage them to consider the self-management activities. So in other words, because concerns go up, the patient might have gotten sort of off course. Don't think about that being off course as that the patient has lost motivation. It's probably the case that they're off course because they're stressed and their concerns about diabetes treatment have gone up. And so the relationship with the provider, we believe, can be very, very helpful getting the patient back. The needs and concerns analysis that I talked about a little bit ago becomes a really useful way of starting that conversation. And then there's a second very simple strategy that for many, many people, they find really helpful. And that is really what we call shared decision-making, which is something that is so commonly aware of by the healthcare providers. And we know that this is really an important aspect of self-management support. And I like to use a strategy, we call it the SURE test. And so it's just S-U-R-E-S. Are you sure about the best choice for you? Do you understand the benefits and risks of each option for you? Risks are you clear about which benefits and risks matter most to you? And do you have enough support and advice to make a choice? So those 4 questions can be very useful in helping us to get the patient who has, let's say, been thrown off their diabetes self-care regimen back on. And so it's very much around this collaborative, supportive relationship that we know is in some ways the essence of diabetes management.
Thank you to Michael Vallis, and thank you for listening to this podcast, produced by MedWire News for Medicine Matters Diabetes. Please subscribe for more, and don't forget to visit diabetes.medicинematters.com for news, expert opinion and practical advice about caring for people with diabetes.